Hi, I'm Dr. Ed Weisbart, and I am a proud member of good old-fashioned traditional Medicare. I say I'm proud of that because Medicare is a fabulous program. Traditional Medicare has been saving seniors' lives, it's been improving seniors' health, and it's been actually saving our country a fortune by really controlling the cost of healthcare. Medicare does a great job at rescuing seniors from bankruptcy. I don't know where we would be without the traditional Medicare program today. But the reason I want to talk to you is because aside from traditional Medicare, there's a separate program called Medicare Advantage that has some issues going on that I think you should know about. And the issues that I'm going to describe to you in Medicare Advantage are very similar to issues that are going to crop up in a new concept called direct contracting entities. But those direct contracting entities are really brand new. We don't have much data about that. So I'll be talking to you about the data from Medicare Advantage about this particular trick that they can do to increase the money that they're paid by Medicare. I think it's important to understand it because it has implications for all sorts of reforms. And I believe it's a direct threat to the Medicare program that so many of us know and love. The gambit that we're trying to talk about tonight is called upcoding. And it's an arcane term. But the Office of Inspector General just recently declared that upcoding is a major driver of improper payments in the Medicare Advantage program. And that means that they are essentially being able to drain funds from the Medicare Trust Fund, and that has an impact on our premiums and all sorts of things. So we need to understand this. To start, we need to understand what Medicare Advantage is, and it's basically following a long history of privatizing Medicare. So, Medicare, traditional Medicare is set up so that we pay our taxes, of course, and then that funds the Medicare program. Traditional Medicare directly pays physicians and hospitals and other organizations. So Medicare is pretty direct in how they work this out. There are some Medicare managed administrators, but it's pretty much run by the Medicare program. Separate and apart from that is what's called Medicare Advantage. So here, instead of Medicare having a relationship with the physicians and hospitals, Medicare doesn't have that for these people, and instead it pays insurance companies, commercial insurance companies, Aetna, Essence, Anthem, and others. So instead of paying doctors directly, in Medicare Advantage, the federal government pays our money to the insurance companies who then pay doctors and hospitals. There's a number of issues with that arrangement beyond the scope for tonight, but you need to understand that that's traditional Medicare versus Medicare Advantage. Within Medicare Advantage, there are a number of things that concern me. The one tonight is what you could almost call the Medicare Advantage upcoding money machine. So let's explain this. Primary care physicians submit their claims, their bills for what they did, and on those bills, they write down diagnostic codes, numbers that describe the specific diagnosis that a patient has. And then those codes are sent into the Medicare Advantage plan because that's where they're going to get paid, as we mentioned a moment ago. The Medicare Advantage plan then can use those codes to submit to Medicare a description of how sick or healthy the patients are. So the Medicare Advantage plan tells Medicare, look at all these diagnostic codes that the primary care physicians are submitting. And somewhat appropriately, conceptually, Medicare then pays the Medicare Advantage plan more to take care of patients who have a bunch of high-level diagnostic codes. If Medicare Advantage plan is paying for sicker patients than anybody else, than traditional Medicare, it only makes sense that Medicare would be paying the Medicare Advantage plan more money for the more complicated, sicker patients. And indeed, that's what this shows. The physician enters a diagnostic code showing that the patient has these illnesses. That goes to the Medicare Advantage plan, who then tells Medicare, hey, look, I got all these sick people, pay me more per person because look how sick they are. That fund doesn't come out of thin air. The money to pay the Medicare Advantage plans comes directly from either the Medicare Trust Fund, which has to support this, or from Medicare members through the course of paying their premiums. So that's where the money, of course, comes from. There's no magic money. And then the Medicare Advantage plan can use that to make some slight, sometimes more significant improvements in what kind of insurance product they offer. A most notable one is that the Medicare Advantage plan uses these extra funds to lower or sometimes eliminate any premium, so that some people can actually join Medicare Advantage for free, maybe even not having to keep paying their Medicare Part B premium. So because they're able to figure out a number of tricks, one of which we'll talk to tonight, to get more money out of Medicare, they're able to offer more robust benefits sometimes and reduce the premium. So getting those up codes, getting the higher coding from physicians is critical to being able to offer lower premiums and expanded benefits. And then when they do those things, of course, more people are lured in and they join the Medicare Advantage plan. The plan grows. What happens when the plan grows? Well, these are often private, commercially owned, for-profit companies, which then are able to offer higher dividends, more stock buybacks, and more profits to the bottom line for the practice owners. Profits that, as we showed earlier, are coming out of the Medicare Trust Fund or seniors paying premiums. Those dollars then, of course, are used to stimulate more primary care coding. If they can come up with tools to get more primary care doctors to submit more complicated codes, that's the game. That's the money machine. They fund these tools. And I'm going to show you how this coding has become a very effective business imperative for Wall Street. We will get there. So this particular tool we're going to talk about is coding, which essentially drives what's called a risk score, which, as I said, is appropriately gets Medicare to pay the Medicare Advantage plans more if they can increase the risk code. So what is this risk code? The acronym is HCC, a hierarchical condition category, or you could just think of it as the risk code, really. So here's an example of a very healthy 76-year-old who has nothing else wrong with her. And so her risk code adds up to a total of 0.45. And because of that, in 2019, when this particular report was published, Medicare would be paying the Medicare Advantage plan $4,000 per year. There aren't that many 76-year-olds that are in such incredibly good health. So here's one that has some pretty common illnesses. Again, 76 years old, baseline payment is again 0.45 risk code, but she has these other diagnoses, diabetes, congestive heart failure, and a few other things. And because of those extra diagnoses, which are real in this case, so let's say, so Medicare would then pay the Medicare Advantage plan substantially more per year for taking care of this person, since the Medicare Advantage plan has to pay their bills. That's kind of the deal. Sicker patient, Medicare Advantage gets more money. Conceptually, that's the way it probably should work. But, you know, once you set up those kinds of rules, it's whack-a-mole. Here's a new game. Let's figure out how to make those codes the best codes. You know, there's rules for which codes get which payment. There's exact rules about this. And so the game is to come up with the right diagnostic codes, not sort of just the typical diagnostic codes. So for example, obesity doesn't get you anything if you're a Medicare Advantage plan, but morbid obesity, well, now we're talking. Depression, nothing, but major depression, a single episode mild, who would know that's worse? That gives you more payment. And all of these things, these subtle differences in codes, which might even be synonymous, but these subtle differences in codes add up to a substantially higher risk score. And here's the bottom line. Medicare pays the Medicare Advantage plan for this optimized coding $32,000 a year, more than 3 times as much if the primary care physician is more casually paying attention to the coding system. So there's a big game to get to the $32,000 from the $9,000. And that's what we're talking about tonight. How do you do that? Well, these companies are pretty serious about it. And as a consequence of wanting to get higher coding, which gets higher risk scores, there's a whole industry creating a suite of tools to optimize these results. There's an incessant search for more diagnostic codes. And that's why Medicare Advantage plans are often champions of home care visits, of annual wellness exams. These home care visits are not typically a physician coming in to treat you in your house for a real medical illness. No. These are some sort of a clinician, sometimes a very skilled and, you know, wonderful clinician, but a clinician coming into your house in search of diagnostic codes. They want to find something more that the Medicare Advantage plan can use to justify billing or telling Medicare that, hey, our patients are sicker and therefore getting the higher capitation rates. So there's an incessant search for more codes, and that's why they emphasize some of these kinds of things. They also have the ability, the Medicare Advantage plans have the ability to search through your medical record to find more diagnoses. You would think, oh, wait, HIPAA, there's this law that says that you don't have access to my medical records. And oh, you do. There's exceptions to HIPAA, TPO exceptions, treatment, payment, and operations. So if you're involved in delivering Medicare benefit and you have you can get an exception to HIPAA for either treatment, payment, or operations. And so because of those exceptions, which makes sense, yes, the Medicare Advantage plans can data mine your electronic health records, and they can use that to come up with more diagnostic codes and a whole suite of other things. Most of the exciting developments that I'm aware of in artificial intelligence and machine learning software, those are happening specifically funded by the interest in searching for more diagnostic codes and other gimmicks to get more money out of Medicare Advantage. The second suite of strategies here is to, frankly, incent poor blokes like me, primary care doctors and other physicians, to submit more and better codes. So there's incentives for reaching the business metrics. There are sometimes just direct financial incentives, and we'll unpack that a little bit. And then finally, of course, they price their products strategically to get the best results. So if they make their price too low, Medicare Advantage plans, if they don't charge enough of the premium, then of course they lose out on revenue. They're leaving money on the table. If they price their plans too expensively, well, then they're not going to get the membership. So they have very sophisticated tools to come up with the exact right price for their market to get the maximum of profitability, growth, and the modicum of expanding Medicare benefits. So there are large new segments of industry, home healthcare visits, as I was talking about, analytic startups. There are modules within the electronic health record to drive the capture of these codes. We mentioned some of these other things. There are Medicare Advantage focused primary care startups, and then strategic building. All of these things that I'm talking about are designed to improve outcomes, and we all like better outcomes. But notice that these are tools designed to improve the financial outcomes for the Medicare Advantage plan, not so much to improve anything clinically, maybe some, but not very much. And they have become terrific at this. It's become a core competency. So because these risk scores are worth so much money, Medicare Advantage plans have figured out how to do this. So if you look back over this 10-year, 9-year, 8-year period, you'll see that the average Medicare Advantage risk score has gone up pretty dramatically and consistently. So they've gotten good at this. Medicare Advantage plans have gotten skilled at scoring their patients higher than traditional Medicare patients. That's what this chart shows. And I can hear the skeptic in the crowd saying, well, Dr. Weisbart, that's because the Medicare Advantage plan has sicker patients. They've been attracting the sicker and sicker patients. And that's why the risk score has been climbing. Au contraire, that has been looked at very carefully. They're trying to figure out, are Medicare Advantage plan patients getting sicker? Is that why the risk score is going up? Well, that's been looked at. It's been looked at with pharmacy claims data. That's been looked at with mortality rates and hospitalization data, and all kinds of deep dives to answer the question, are Medicare Advantage plan patients getting sicker? Is that why the risk score is going up? Is that why Medicare is being compelled to pay more per person to the Medicare Advantage plans? No, that's not what's going on. It's entirely that the Medicare Advantage plans have figured out how to capture more and more aggressive risk scores to drive up the reimbursements. So how do they do this with primary care physicians? What's the strategy? What are the tactics here? And they have three main ways that they get us to do more coding. The first is that the Medicare Advantage plan sometimes will actually pay primary care physicians more if we code more. Then there's this concept of value-based care, where the contract with us essentially shares a percentage of the Medicare Advantage plan's risk-adjusted premium back with the Medicare Advantage plan's primary care physicians, and we'll explain this more in a moment. And then finally, the Medicare Advantage plans are starting to actually purchase primary care physician practices so that they can completely internalize the profits of gaming the risk scores. So first, incent us to code more. How does that work? Well, for example, Clover Health, which is a Medicare Advantage PPO plan in various states, established since 2013, proclaims on their website, which is on the bottom of this slide, that we provide Clover Assistant. We provide doctors with our Clover Assistant technology at no cost to the primary care doctor. The Clover Assistant will help your primary care doctor get a more complete view of your overall health. Well, of course they're saying that in public because that's a lovely thing. Who would say that's bad? It's sounds lovely. And here it is from them. Here's how it works. They take all of this data and it pumps into the Clover Assistant as a synthetic solution. And then there's all of these solutions on the right-hand side. I am unaware, frankly, of any physician in practice who says that this has added value to their clinical practice, and that I'm unaware of any evidence, compelling, accurate, objective, validated evidence that this is actually improving anybody's quality of care. However, if a doctor puts this on their desktop, their electronic record, and they use this, here's one of the things that they tell doctors: just use it. We don't care if it changes, just have it there and use it. We don't care. I'm not compelling you to change any codes. Just use the Clover Assistant. And we, as a PPO, as a Medicare Advantage PPO, will pay you $30 more per visit on a weekly basis just for using it. No risk, just guaranteed income bump. And because they know that having this on our desktop and getting us to use it guarantees them that they're going to be able to bump up their risk score and get, as I showed you, pretty phenomenally increased capitation rates from Medicare. So a pretty substantial incentive. As a doctor, you would be very tempted to use that. So that's one of the ways. A second way that we're being encouraged to find the diagnostic codes is to do things that, you got to really wonder how this happens. So one example would be there are programs in place to encourage us, doctors, to order carotid artery ultrasounds, to use one example, on Medicare Advantage patients who have no symptoms. The idea being that if we can find somebody who's got a blockage in their carotid artery, well, who doesn't want to know that? Don't you want to know if you have that? So you've seen ads like this, probably this particular one, this one example, but these are all over the place. Well, free vascular health screenings, and as a patient who hasn't perhaps researched the question, it seems, well, it's great. Thank you, Medicare Advantage plan, a free outreach for a vascular health screening. Everybody wins, right? The patient sees, well, I get this free test, doesn't cost me a penny. If they find I've got a blockage in my neck artery, well then, hooray, let's get that fixed. I didn't get a stroke. Sounds like a great thing. Patient gets stroke prevention, and it's not just the patient who benefits. The vascular surgeons and the hospital can bill for more services, since that's how we pay people. And just by coincidence, the Medicare Advantage plan can get higher codes to submit to Medicare. So this is great, right? The market is fully aligned. The patient gets better care, and surgeons and hospitals can bill more, and the Medicare Advantage plan gets more money. Seems like a great thing, right? Except for one small problem. You're not supposed to do that test. Small problem. The United States Preventive Services Task Force, which is a group you should know about if you need to try to find some relatively independent, non-biased source of, is this a good test to do or a bad test to do? USPSTF, United States Preventive Services Task Force. And they've looked at the question about carotid artery ultrasounds. Is this a good thing or bad thing to do in an asymptomatic person? Turns out they have recommended twice now, both in 2014, then and again this year, 2021, don't do this test. We have the answer. And the reason that they recommend against doing it is because if somebody has symptoms of a small stroke, a warning sign, it's called a TIA or a RIND or whatever, or they had a stroke, if they actually have symptoms, then we know that they are at high risk of having another potentially larger stroke. And so that's the person in whom we should do a carotid artery ultrasound to find a blockage that we can fix to prevent a stroke. The problem is when you do these screenings tests on people who don't have any such symptoms, most of them don't have strokes. Most of them really ultimately would not have had a stroke. However, if you find the blockage, we're all kind of freaked out by finding this blockage. And so the reason you did the study in the first place was thinking if you find a blockage, you're going to get an endarterectomy or some procedure to clear out that blockage and prevent a stroke, right? That's a great idea. It's completely wrong because it turns out that the intervention, that procedure to clear out or bypass or do something to your carotid artery, there is some risk to that procedure. There is risk to just doing that thing. And it turns out that the risk In 2014, and even today, still, now maybe the technology will improve and this will change, but even as of today, the risk of doing a carotid endarterectomy or any surgery to fix the blockage in your neck, the risk of that procedure is worse than the risk, than the unlikely chance that you would have a stroke from an undetected blockage. So for that reason, because the risk of the intervention is worse than the benefits of it, the United States Preventative Services Task Force is consistently said, hey, if the person doesn't have any symptoms, do not get a carotid artery ultrasound. But, if you find any evidence of the plaque in the artery, the MA, the physician's going to submit that diagnostic code, and the diagnostic code gets sent in for Medicare to pay the Medicare Advantage plan nearly $3,000 more on that person. So the Medicare Advantage plan stands to make $2,800 per year for the person who really has carotid artery obstruction, even though it was dangerous, potentially deadly for the Medicare Advantage plan for anybody to have looked and found it. That's called a perverse incentive. That's called a perverse incentive. And they don't just get that $2,800 once. As long as that person's in Medicare, is in that Medicare Advantage plan, that code stays with them, and it's $2,800 for the long haul. So it's potentially a lot of money for a relatively inexpensive test, except, by the way, it might kill you. So that's one example. So screening increased the plan's wealth, the Medicare Advantage plan's wealth, and it increased the patient's risk of a stroke. Not a good idea. The second type of incentive is to share risk score payments. So this is a direct quote: overall, physicians in the value-based program with Humana can get 2.5 times more than the fee schedule, value-based. That means that these are people who are being encouraged to find these codes. And on average, sometimes they get 4.5 times the fee schedule. So if they're in this program, if they're not in this program, their fee for their equivalent might be $44 per member per month. That's how they think about these numbers, is per member per month, right? Because that's how the capitation works. But if they get into this program, they may make 4.5 times as much for being involved in these programs that share the risk score payments back with the primary care physicians. Or lastly, they might actually in many cases now they're starting to purchase the physician practices to really internalize all the value. And one of the more recent examples of that, Humana introduced its own brand name group for the primary care physicians that it owns, and it's now active in Orlando. So this is a big deal. This is a big deal. The Committee for a Responsible Federal Budget said that this is worth over this upcoming 7-year period, worth $2 to $3.5 billion. This is worth $2.5 to $3 billion. As I told you earlier, the Office of Inspector General said this is a major issue for funding in Medicare. These kinds of numbers, in addition to draining the Medicare Trust Fund and essentially leading us towards really a less stable finance for the entire Medicare program, these kinds of numbers are the kinds of numbers that get attention on Wall Street. So that's a big deal, because we have, on the advocacy side, we've been focused on the Medicare Advantage piece, right? We've been focused on everything I just said. All of the numbers I've just given you come from our experience with Medicare Advantage, and in the healthcare reform advocacy movement, we've been sort of watching with some trepidation how Medicare Advantage is using all the gains we've showed you to be able to lower premiums and do other things to attract membership. And hence, here's been what almost looks like a relentless march of growth of Medicare Advantage members. And to be honest, many of us have not paid enough attention to what is, from Wall Street's perspective, a bigger potential financial opportunity. Yeah, Medicare Advantage has been growing and using all the tricks that I have showed you, but Medicare, traditional, good old-fashioned Medicare, the kind I have, the kind that 60% of seniors have, that's potentially some untapped market, because a lot of the stuff that we've been talking about and other similar things that we have not covered tonight, those are things that are off limits in traditional Medicare. These things don't happen. A lot of the things that happen to drain the trust fund to Medicare Advantage, commercial insurance companies, those don't happen in traditional Medicare. And so the for-profit, private equity, venture capital world has been looking at this 60% of untouched Medicare members and thinking, I want to get my hands on that. And that's where this new concept has been, this new pilot project has been coming up called direct contracting entities. Direct contracting entities is essentially a way to introduce the for-profit corporate world, not just into Medicare Advantage, but into traditional Medicare. So we showed you this, right? We showed you traditional Medicare with very few, if any, real intermediaries, perhaps some administrators, but no real intermediaries, versus Medicare Advantage. So direct contracting entities introduce new risk-bearing intermediaries into Medicare. They're today in the pilot phase. They are not taking over all of Medicare tonight, but this is a pilot project that's sort of in the early stages. And if we want to protect Medicare from all the same shenanigans that I was talking about and more, now is the time that we need to focus on this. Most of these new things, these direct contracting entities, which I'm not going to go through in detail tonight, though, most of them are investor owned. So some are owned by physician groups and by specialty providers and ACOs, again, an acronym is beyond tonight's scope. But most of them are owned by investors. Most direct contracting entities are either publicly traded or publicly backed by private equity and venture capital. And 6 of them are owned actually by commercial insurance industry companies. 6. There are 53 of them today in 2021. There are 53 of these direct contracting entities, and 6 of the 53 are owned by insurance companies who have all the skills we were just talking about from Medicare Advantage. They have those skills. Those 6 are not just 6 out of 53. They actually represent the majority of people that are being enrolled into direct contract entities. So those 6 are only 6 out of 53, but they are the largest group of companies here, of organizations here. So direct contract entities, to spend a little bit of time on it, is a project that was begun under the Trump administration as a pilot project within the Center for Medicare and Medicaid Innovation. The Center for Medicare and Medicaid Innovation is something that was created de novo as a part of the Affordable Care Act, because at the time the ACA was enacted, there was quite a probably valid sense that there was anti-reform inertia within the Medicare program. And so the ACA created under Section 3021 with a small fortune of money, they created this new department called the Center for Medicare and Medicaid Innovation. They've done a lot of things since they've done dozens of pilot projects, some better, some worse. And so some of it, it's a good conceptual thing here. A CMMI pilot can start as a pilot within the Medicare Innovation Center, and then if Health and Human Services and Health and Human Services actuary, in fact, declare that it's a success, they can roll it out across the entire book of Medicare business. So they have to meet some criteria under the law. They have to show that their pilot program reduces spending without decreasing quality, or improves quality without increasing spending, and doesn't deny or limit coverage or provision of benefits. So that was what they were. If they can meet those criteria, if they decide that they have met those criteria, then these innovations can be rolled out across the entire book of Medicare business without having to go back to Congress for any further approval. So it's entirely in-house for Medicare to make that decision. So these new DCEs are going to be under pressure to do the same upcoding trick, right? So the DCEs, the direct contracting entities, engage primary care physicians. That's the way they grow. And then Medicare contracts the DCE for that primary care physician's patients. And then the direct contracting entity can maximize their capitation from Medicare by driving upcoding in exactly the same way we were talking about. So as it turns out, under the rules, the reward for upcoding a direct contracting entity is not as incredibly dramatic as I spelled out here for Medicare Advantage today, but it is still very substantial. The exact percentage is something that is not completely understood yet, but it's going to be a pretty substantial piece. So this gambit that I was showing you tonight applies to not just Medicare Advantage, but it's the same mechanism that's going to be applied under the direct contracting model, unless we stop the direct contracting model. So this direct contracting model really represents a potential privatization of the rest of Medicare. There's 60% of us in Medicare who have traditional, good old-fashioned Medicare, original Medicare, and then 40% of us have, 41% I think now, are in Medicare Advantage. So that 60% is not privatized, not commercial. It's entirely publicly run and runs beautifully and effectively. Direct contracting is a way for the for-profit industries to fully privatize bit by bit, not tonight, but over the next few years, fully privatize our public good, which is a complete violation of the spirit of a public health program and changes the focus from better national health into larger corporate profits, corroding the value of a public health plan, increasing the opportunities for profiteering, and giving us a complicated message when we're trying to figure out the future of Medicare for all. If it turns into this big for-profit commercial business interest, well, it's going to be harder to figure out how exactly to advocate for it. So thanks, and let me stop recording. I can figure out how.